Welcome to CP Stated, the podcast where we explore the people, ideas, and innovations powering progress for individuals with disabilities across New York and beyond. In this episode, we're joined by Dr. Maria Kansas Devine, Chief Medical Officer at the Center for Disability Services and a board-certified family physician. Drawing on her extensive clinical experience, Dr. Kansas talks with us about improving medical care for people with intellectual and developmental disabilities. We'll dig into the role telehealth can play in increasing access, how unconscious biases can affect patient outcomes, and what patient advocacy looks like in a truly person-centered model. Along the way, Dr. Kansas offers practical advice for providers and families to ensure every patient receives the respectful, high-quality care they deserve. Let's get started.
I think the most common misconception is that there's some fundamental difference between people with disabilities and people without disabilities. People with disability require what all people need. They need a careful, thoughtful clinician. They need time to express themselves. They need reassurance that they are being heard and well cared for. They're people first, and that may seem like an oversimplification. But I think many clinicians approach them as a disability and not as a person first. The medicine is the same. The preventive guidelines are frequently the same. Sometimes the method of acquiring information may be different. A clinician might need to use multiple resources if the patient is unable to provide history. But verbal patients are often very able to express their needs if they are given enough time. And time, as we know, is a very precious commodity in today's medical world. So I think caregivers and medical systems in general need to be able to accommodate different needs. But basically, the care is not different. People are the same.
That's great. Now, I wanted to ask a follow-up. Is there anything different that you would advise clinicians who are treating patients who are not verbal?
So I think it is still important that the clinician develop a rapport with the individual, even if they are not the one directly answering questions. Making eye contact with that patient, assuring them that you are a friendly presence is so important. But the one thing that we need to do when we're taking care of nonverbal individuals is we need to recruit other people to give us information. We need to keep especially good documentation so that as caregivers may or may not change, that information is somewhere. I think it's also important that we contact the right person who might have the information. It's not always the person who presents for the appointment. It might be a parent, it might be a nurse at a house, it might be a different direct caregiver who just happens to not be at that appointment. So I think we all have to be willing to pull that information from other sources. And I think that's especially true in the hospital or in a specialty situation where they may not have a continuous relationship with that person, or they might not have a medical record that goes back 10, 20, 15, 20, 35 years. So I think the demand on all of us is to make that extra step to communicate with others.
Now, I mean, you've been in the field for quite some time. In your opinion, how well are medical professionals trained to care for people with disabilities in medical school and in continuing ed and throughout their careers? What are you seeing?
So, medical schools in the United States right now are not currently required to have a specific disability curriculum to be certified. So some schools do, most do not have any specific education on caring for people with disability. So most students will experience disability either because they have a family member, so on a very personal level, they may have an experience, or it's somewhat up to chance whether any particular patients happen to cross their paths during the course of their training. The good news is, however, there is work being done to develop a more intensive and specific training to improve skill and sensitivity regarding special needs individuals. The American Academy of Developmental Medicine and Dentistry have sponsored a series of grants, which is designed to support medical schools in developing a curriculum. And my own alma mater and the school that I work with, Albany Medical College in Albany, New York, has participated in this grant, and I have participated in teaching students and residents there. There are also a few residencies or fellowships in advanced training in DD medicine and dentistry, but they're still pretty few and far between. And there is not a boarded specialty in developmental medicine at this time. There is in pediatrics, but not for in adults. So most providers learn sort of on the job and by chance, which is unfortunate.
And what, till now, why do you think that has been the case? Is it a market demand that the disability population isn't as large as, obviously the general population? I guess I'd like your opinion on sort of what factors contribute to that lack of training.
I think it's multifactorial. I think until recently, developmental medicine was solely a pediatric specialty. And a lot of that was because people with disabilities were not expected to and did not survive very far into adulthood. I think since, state school system has broken down for good reasons, and we are seeing more individuals more mainstreamed into the medical system. I think a lot of that has changed, and we are seeing adults with disabilities live a normal lifespan. And so this is sort of backwards, but is now creating demand for more specialty knowledge. The flip side of that is really based on insurance. Individuals who are Medicare and Medicaid funded will tend to go to more of a publicly funded or non-for-profit medical model than be in the general medical population. And so the providers who give them care tend to learn more because that is the makeup of their population.
Gotcha. So we talked about communication being key, some of the barriers that the supply of clinicians face. What are some other barriers that people with disabilities face when trying to access clinical care?
So there are multiple barriers in getting care, getting adequate care, and getting adequate follow-up, from square one. So just starting with getting to care, if presuming you already have an appointment, you have to get to the appointment. And for wheelchair-bound individuals who don't have access to a car or a van, that usually means getting Medicaid transportation. Medicaid transportation requires that you access a website or make a telephone call at least 24 to 48 hours prior to the appointment, which means that if you're sick today, either your visit's going to be delayed or you're going to call an ambulance to go to the ER, as that's your only resource for acute care. So that's a huge one, transportation. And that also limits, what appointments you can make. So you can't make an early morning appointment. You can't make an after hours appointment. You have to go by the transportation hours. Likewise, things like weather, if you're in a wheelchair. If you live in the Northeast and it snows and you can't get out to the Star bus, then you're not going to your appointment. And there isn't any accommodation for those kind of unanticipated barriers. Like I said before, I think insurance is another huge barrier. In New York State, only 62% of doctors accept Medicaid. And this is largely related to very low reimbursement rates. And these haven't been adjusted in decades, these rates. They tend to be 50 to 60% of the Medicare rate, which is already discounted compared to private insurance. And with the cost of doing business nowadays, for many private physicians, that rate is not going to be sustainable. So that, again, forces individuals with disability to seek care in the few locations that do accept Medicaid. Once they're actually there, they have an appointment, they're at the doctor's office, there are lots of physical barriers to getting an appropriate exam. Most doctors' offices are built to accommodate an average person. So the rooms tend to be small. And if you have a wheelchair and one or more caregivers, that room may be a very tight squeeze or not be able to accommodate you at all. Most doctors' offices do not have equipment such as lifts to transfer a wheelchair-bound individual who can't self-transfer. And if a person can self-transfer, the exam table is usually too high to achieve that successfully and safely. So we need more flexible equipment and more access to it. We need lifts, we need tables that go up and down. We also need staff. We need extra staff. So a person may be able to transfer, but they may need staff assistance. They might need a staff or two to support them during a medication administration or a vaccine, or even performing screening tests like we talked about for diabetes or EKGs in an office setting. Very often in an office setting, there may be one support person per provider. And usually you need at least 1.5 to 2 per provider ratio if you have a high percentage of individuals who are wheelchair bound in your practice. You also need sensitivity and training to help prevent or de-escalate behaviors, particularly true in individuals with nonverbal autism. They often need additional support to complete, required examinations. Sometimes what we lack is just time. Most provider schedules are built to accommodate 15-minute appointments for general rechecks. And if you need additional assistance, either to transfer or to communicate, 15 minutes is just not going to work. And most systems are rewarding providers based on volume, not necessarily quality.
What's the effect of telemedicine on the quality of treatment, the time commitment? What are the benefits of telemedicine? Are there any downsides to telehealth that you could see? I guess, how does that affect the quality of care for people with disabilities?
So for me and my former organization, telehealth has been a game changer and has certainly helped people with developmental disabilities, particularly for psychiatric and social work treatment. The ability to have a visit in your own home without transportation needs has dramatically improved attendance. It is not infrequent that we see individuals who can't attend their appointment because that day they just don't want to leave the house, but would be able to complete a telehealth visit. We have people who travel over an hour to get care from where they live, either in a rural setting or just, because of traffic and transportation issues. And so for people who are dependent on public transportation or others to transport them, telemedicine can greatly improve their access to care. I think it's in a primary care setting, which is likely not going to be covered in the future. We found it tremendously helpful during COVID, as we were able to see and do a preliminary assessment of individuals who tested positive or had mild symptoms. Just getting an eyes on them to evaluate whether they were in distress was enormously helpful. And we were able to do it without exposing the rest of our vulnerable population to an infectious disease. We also find it really helpful for people who, like I said before, can't get in, either because they have a behavior or maybe just need to review things that don't require an in-person exam. Now, it's not uncommon to see a person over telehealth do initial assessment and then say, well, if you're not better in 2 days, then I'm going to need to see you in person. But it is a very time-effective and useful time spent to have that eyes-on contact with patients. it also enhances communication. So I can talk not through my nurse or not through the portal or not waiting for an in-person appointment to discuss important results or outcomes or make a plan for what to do next. It builds relationships. And I think telehealth has been incredibly useful in primary care and should continue to be so.
You talked about sensitivity training and increased need for sensitivity training. Can you tell us how, biases, even, unconscious ones, affect the quality of care for people with disabilities?
Sure. I mean, we all have biases. They're built into every decision that we make, whether clinical or otherwise. We start with ourselves and what we perceive as valuable. And in medical school and in medical training, we are trained to make clinical decisions quickly, based on a collection of circumstances. And that's very valuable in an emergency. It is less valuable in long-term care. So sometimes those biases can lead us down the wrong path. And I think the most common and most dangerous bias that I see in our health system as a whole is in viewing a person with disability as somehow less than the provider, who is a highly educated and practiced medical provider, and somehow not being a highly educated person is viewed as somehow less deserving of full care. It is not a conscious decision. It is not one done with malice. But unless healthcare professionals purposely examine their thought processes, that is going to be a bias. So I think we need to train professionals that a nonverbal, non-ambulatory patient still has a life that is valuable to them and valuable to their loved ones, even if it is not a life that those providers or caregivers are envisioning for themselves. I have seen in hospital settings in particular, but sometimes in specialty care, a jump to DNR, to do not resuscitate. And there's a whole, in New York State, there's a whole system through OPWDD and mental hygiene legal services that is designed to make sure that there are appropriate criteria for DNR in order to protect individuals from that very bias. There are the other bias that I see is a bias towards blaming medical conditions on the disability. So say an increased tremor in a person with disability, with cerebral palsy, for example, would be blamed sort of offhand on the cerebral palsy. Whereas a new neurological development should be questioned, because cerebral palsy is in general a static neurological deficit. So there's some biases that have to be actively challenged by the providers. Another example would be a person with autism who has increased behaviors. So that might be a reflection of their autism, but it is really important that the first step is to rule out other triggering medical issues. The sort of the most famous one is a person, which we had in our own clinic, who had increase in headbanging behavior. And after lots of antipsychotic medications, it turned out they had an abscessed tooth. So it's important that you not immediately jump to, that a provider not immediately jump to, well, this is a behavioral issue, not a medical one. We got to rule out the medical first, rule out any psychological stressors as well, before you just treat it as a reflection of their autism.
Can you speak to the role of interdisciplinary collaboration in providing effective care for people with complex needs?
Glad to. So, I can only speak to my own experience as a family doctor, and granted, I am completely biased in support of having a trusted family physician who knows a person over time. I think that longitudinal relationship is critical in navigating today's healthcare system. But the most successful cases have always been when providers talk to each other. We can't just rely on paper consults going back and forth, or portal messages. My most successful cases have always been when either I reached out to a provider or another provider spoke with me directly. I often, as their primary care provider, have information over time and can tell them accurately, why did I send them to specialty in the first place? What do I know about that individual? What is their baseline? What other workups have we done? And even though our electronic records are better at talking to each other, the amount of information there is so copious that reading it all is practically impossible. So conveying verbally a summary can take 5 minutes, whereas you could spend hours and hours reading every record and still not know exactly what this person in front of you is all about. The other thing that happens with electronic records is if you make an error somewhere along the line, if you put in the wrong medication or the wrong result, they stay there forever and they often get reproduced over and over again. It's not unusual for a patient to come to me and say, this was in my electronic hospital record. It says that I have this. And the answer is no, you don't, but somebody put it in somewhere along the line. So in my opinion, interdisciplinary collaboration, particularly in provider to provider speaking communication, is critical for everybody, whether you're have a disability or not, because the healthcare system is so complicated.
And it seems with the pipeline of providers sort of trickling, as you mentioned earlier, establishing those longitudinal relationships has to become more and more difficult over time.
I mean, that's probably a whole talk in and of itself. The support for developing primary care in this country is just not there. We have a backwards pyramid where the primary care provider numbers are smallest and the specialists are the top of the pyramid is the biggest. So our whole system is balancing on a point, a very small number of primary care providers. And it should totally be the opposite. So if we want to get into that, I'm more than glad to get on my soapbox. But I think medical education needs to support primary care, whether it's paying their tuition or interest-free loans or something to balance so that new doctors, new providers don't feel like they have to go into a top paying specialty in order to pay off their debt. Right now, the drive is definitely towards specialty, and it has been for a long time.
I guess, does the tail wag the dog then? Does that reflect in the diagnosis that's given? Do you see more I don't how can I say this? Do you see more diagnoses that push people towards specialists as opposed to just general, primary care? Because that's where the doctors are?
Maybe to a degree. I think what we're seeing is an overwhelmed primary care demand. And so that if the inclination would be, if anything is complex or consuming large amounts of time, it's sometimes easier and quicker to refer to specialty. But the flip side is that now we're waiting 6-9 months to get into specialty. So I know from my own experience, often, we don't let patients suffer for 9 months. So often by the time the specialty appointment rolls around, we have already done a complete workup, achieved a diagnosis, and started treatment. So there is a push towards specialty, but specialty access is not what it once was either. On top of, I hate to sound like a broken record, but on top of getting specialty care, insurance plays a role there too. Medicaid patients may not be prioritized in a private practice. And the specialties are starting to be overwhelmed as well. Medical liability has a huge role in that too. Nobody wants to be wrong or delay a diagnosis. Americans' expectation for, right on the first try and what is a very complex group of knowledge is challenging also.
It's a great point. How can family members, support staff, people other than the individual be better advocates in clinical settings? And on the flip side of that, are there certain boundaries that family members and support staff maybe shouldn't cross when advocating for care?
So, in my experience, family members and support staff are critical advocates in care settings. Most of the time, they know the patient best. And I learned very quickly while working at the center that if they say something is wrong, there's almost always something wrong. They might not be able to give you any more information than that, but that this person who they've known for a long time is not acting like themselves. So I think the provider's responsibility is to acknowledge that um, that competency that they have about their individual. I think this goes back to the relationship a lot. They need to know that they're being taken seriously and that they have trust that their provider is not brushing them off. The downside of that is that sometimes when you don't know what's wrong, but you think something is, the response can be too much intervention or too much testing or too much prescribing. So I think it's important that the advocates are willing to discuss the options. And sometimes treating is not the best option. More medication has its own risks. And so I always try to discuss with my patients, let's try this and see what happens. I mean, obviously that we're not talking about critical illness here. But a stepwise approach in evaluation and open communication is really useful. And trying a small thing and then reassessing in a short period of time and knowing that that communication is going to happen prevents a lot of over invasive testing. And I think having a good team is critical here because, as a practicing physician, I didn't have time to make a follow-up phone call for every person I saw. But I had my nurses sometimes reach out and say, Dr. Kansas was wondering if that thing that we tried has been helpful. And sometimes it was, and sometimes it wasn't. And then we could discuss, okay, well, what we talked about was if that didn't work, we would do X. And so, again, that stepwise approach and that relationship is really helpful. As far as boundaries go, it's always tricky when patients or caregivers come in having done, I'll put in air quotes, their own research, because the internet is full of false information. I always like to know, okay, well, what did you read? Where did you get this information? Because some of it is valid and some of it is not. And it's all written to look scientific and real. This is obviously a moment in politics where that is rampant. But I think, and I have found caregivers who are very demanding at onset, but as we get to know each other.
Oh, apologies.
That's okay. Everybody okay?
Yeah. I think we have I don't know if it's a squirrel, one of our farm animals or what, but I'm sorry, if you could take it from, you have, the moment in politics and you've met
cut that out
caregivers.
if you want. That was just my side.
Yeah, no, that's fine. I'm comfortable leaving it if you are, but we'll see how it comes out in editing.
So I think I have had caregivers and patients who have been, I'll say, demanding when we first meet, who have read something that they insist on me addressing or treating in a certain way. It's happened a lot during COVID. And I had to make it very clear that that was not a treatment or even a testing plan that I was comfortable with, or that was part of my training. But over time, as they realize that I am listening to their needs, which sometimes is an expression of anxiety, that I am listening and hearing, that even if I don't do everything they want, they know that I am on their side. And that builds trust over time. And trust is the reason I went into family medicine, because those longitudinal relationships are honestly what makes practicing medicine worthwhile.
If there was a single thing, one small change that, providers today could make to increase the quality of care for people with disabilities, is there something that you can think of?
So I think there are a few things. Some are easier to do than others. And I think both providers and caregivers and patients have some things that they could do better. The extra 5 minutes of communication with other providers, obviously you're not going to have to call every specialist about every visit, but talking between providers and specialists is a low energy, low cost thing that can really enhance care and communication. I think taking a couple of minutes and reviewing patients' chart ahead of time and identifying as a provider in your own head what are the things that I want to accomplish during this 15 minutes allotted time. So it might be, okay, this patient has diabetes and hypertension. I need to talk about their diabetes. So that might be what I go into the visit wanting. The flip side is for the patient and caregiver is it's important that they identify what they absolutely need addressed during that visit. And while I always encourage my patients to make lists, I do not encourage them to save them all up for one visit, because both sides have to acknowledge that their visit is slotted for 15 minutes, maybe 20. And so if they have a laundry list, they need to expect to schedule multiple appointments. So by setting the priorities ahead of time and preferably even communicating them to the provider via the portal or by a nurse call ahead of time, that can set up that short time for success so that everybody leaves feeling like they had their most pressing medical needs addressed. I can't tell you how many times I have gone into an appointment, they're scheduled for a recheck of their hypertension, say. But the last 2 minutes as I'm wrapping up, I get, oh yeah, I had chest pain the other day. That would have been good to bring up in the beginning, and that would have changed the priorities. So I think pre-visit planning on both sides is really helpful. And the acknowledgement of the time crunch that the healthcare system has imposed is really important. Most providers do have the ability to say, I need 30 minutes for this patient. But sometimes you don't know you need 30 minutes till you're in it. So I think acceptance of time and time limitations is really important for both sides.
Dr. Maria Kansas, I want to thank you for being on CP Stated and sharing your infinite wisdom with us. I hope that this was an enjoyable experience for you.
Thank you for the infinite. I'm not so sure about that, but thanks. Appreciate it.
Thanks for listening to CP Stated. We hope you'll subscribe, share, and join us for more conversations about the individuals, ideas, and innovations shaping services for people with disabilities in New York and beyond. Until next time, stay connected, stay committed, and stay CP Stated.